The diabetes one. You guys forgot to remind me for the dot. Look for the red dot. Anyway, we're recording now. You guys reminded me the second time. Okay.
Well, I saw it and I was like, well, maybe you're...
It's because I played that video in the beginning and it threw everything off. Anyway, so remember, with endocrine, every hormone, is it too much or too little? So here we go with the thyroid. We have too much thyroid hormone, hyperthyroidism, too little, hypothyroidism. And there's a couple other things we'll talk about with cancers and adenomas and whatnot. So quick review, where they're located. Remember, we have the 4 parathyroid glands. So remember, always ask any patient with a thyroidectomy, do you still have your parathyroid glands? Because they should. If they don't, and they take it all out, sometimes I'll take the PTH, the parathyroid gland, and I'll put it like in your forearm or something like that. It doesn't matter where it is. As long as it's got blood supply, it's still going to work. It just happens to be located in the thyroid. You can take it out. You can put it somewhere else. As long as it's got blood supply, it'll still sense the calcium, and it'll still release the hormones. And we have 2 lobes, only 30 to 40 grams, obviously very, very highly vascular. We have the colloids. So anytime you see colloid, that's just not right. Pen's not dead. So the colloid, remember that stores? I think my pen's dead. Anyway, colloid is where we store what? It should work now, even though? Okay. Yeah, it's at 0%, yeah. I taught too much yesterday. Okay, so colloid, that's where, remember, we talked about how we synthesize thyroid hormone. The thyroid molecule bounces back and forth between the colloid space and that follicular space, which is all around that surrounds those colloids. So we talk about iodine trapping, remember everything going back and forth. What I really want you to know is how iodine trapping works. We have to get iodine into iodide. The iodide, which is I2, gets absorbed, taken into the thyroid. The follicular cells, which surround the colloid, synthesize it, and they put it into the colloid, where that starts, and then we have making of the molecules T3, T4. This whole process starts with TSH. Big things I want you to know are the ones that are highlighted in red. Thyroid peroxidase and thyroglobulin. Those are the 2 key enzymes. The thyroglobulin is actually the binding molecule that helps with formation of thyroid hormone. If you don't have these 2 things, you can't make it. So when we talk about hyper and hypothyroidism, you're going to see how things change and are affected based off of these enzymes being present or not. Oh, okay. If it works. Well, I don't know if it works though. We'll have to sync it. Maybe. We'll get it. It'll charge itself after we're talking. Okay, so remember, T4 is more abundant. There's more T4, but T3 is more metabolically active. It gets converted in the peripheral tissues to T3. Whenever we're doing labs, and it got 15%, so we should be okay. The free version is what you want. That means it's biologically active. If it's bound to the protein, the transport protein, it's not active. Why does thyroid hormone have to be bound to a protein to go around? It's not water soluble, remember? It's got to have a carrier. What other hormones require carrier proteins? Steroids. Steroids and thyroids require carrier proteins. Thyroid, remember, is not a steroid hormone, but it acts like it. It needs to carry throughout the system. When it gets to the cells, it goes into the nucleus and starts causing transcription and translation. TSH is the most sensitive and reliable indicator for thyroid function, therefore we use it. If TSH is elevated, decreased function. It's like the TSH is trying to poke the thyroid with a stick. Come on, do something. And nothing's happening, so we need more TSH to try and get more of an effect. Not doing anything because there's no negative feedback. Remember, the thyroid hormone, T3, T4, has a negative feedback on the thyroid and the thyroid and the pituitary and actually sometimes the hypothalamus. So it has that negative feedback, but there's no thyroid hormone, there's no negative feedback, so TSH keeps going and going and going. If you have hyperthyroidism, now you're making way too much thyroid hormone, you're going to shut down the feedback loop and your TSH goes very, very low. So decreased TSH is increased function, hyperthyroidism. So here's our axis. Remember, this is right from physio. Make sure you remember all this stuff. Draw it out however you did before, it's fine. So what are the actions of thyroid hormone? Increase heat production. That's why if you're hypothyroidism, you get cold a lot. Okay? If you're hyperthyroid, you start sweating like crazy because your temperature control is off. Stimulate oxygen consumption. Okay? Allows you to do more things at a given workload. Okay? You don't get winded and fatigued as fast. Tissue growth and maturation. You'll see later on when we talk about little babies and kids who have hypothyroidism, they don't develop properly. Regulate lipid metabolism, cardiac contractility. Anyone coming into the hospital, especially if they're elderly, with a new onset of atrial fibrillation, which is a rapid heartbeat, check thyroids because they go hand in hand sometimes because of these fast heartbeats. And increased intestinal absorption of carbohydrates. And again, remember this is how thyroid works. Got a carrier protein, that thyrobinding globulin is the carrier protein that travels around and carries thyroid for the ride. Has to get into the cell, and it goes into the nucleus and causes all the translation and transcription stuff to happen. Again, thyroid is made for development. We have to tell the cells, start doing something. It's got to get inside into the nucleus. And then here's just another slide talking about the different things that it does with regards to thyroid hormones. Okay, so that's it for thyroid. Now let's go into some thyroid pathology here. Okay, first up is a goiter. Okay, a goiter, also known as diffuse non-toxic goiter. It's just an abnormal enlargement of the thyroid gland, often painless. You can see how big that is. It's going to cause dysphagia. Why? Just compressing the esophagus, that's all. So this is an obstruction that if you got rid of it, the dysphagia would go away. Often painless. Whenever you're talking about these thyroid disorders, know if it's painless or painful. It changes your diagnosis a little bit. So worldwide, it's due to lack of iodine. Okay, US, we don't have this problem because why? Salt. Our salt is iodized. Okay, so we get our iodine from our salt. What else is there? In the US, any cause of a goiter would be either over or under production of thyroid hormones. So we mentioned before in the other classes how if the demand for these hormones goes up, the gland will start to hypertrophy to compensate for that. So in these goiters with overproduction, the thyroid gets huge. Autoimmune disease, so here's your Graves, your Hashimoto's, and a nodular thyroid disease are other causes as well. So again, insufficient T4, T3 production, there is no inhibition on the hypothalamus, so we just keep making more and more TSH, more thyroid stimulation, but because they don't have any iodine, they're never going to make the hormone, and this vicious cycle keeps repeating until you're stimulating that thyroid so much, it just starts growing and bigger and bigger and bigger. And just more negative feedbacks with regards to your iodine intake through our nutrition. Okay, so now let's move on to hyperthyroidism. There's all these pictures of Eli growing up. So, definitions: thyrotoxicosis, just excess thyroid hormone. It's an umbrella term, okay, for hyperthyroidism. Basically, large amounts of thyroid hormone floating around. Hyperthyroidism by itself is a state of thyroid hormone excess resulting from excessive thyroid gland function. So the gland has to be working overtime. What is another way you can get thyrotoxicosis without having any thyroid involvement? Medication. What do you mean? You just take too much thyroid medication. Let's say you forgot you took your pill this morning, so maybe I forgot it. I'll take another one. Now you've doubled your dose of thyroid. It can cause a thyrotoxicosis. You took too much thyroid medication. That's another reason. That's why thyrotoxicosis is an umbrella term for high amounts of thyroid hormone. But hyperthyroidism is separate. Because you can get hyperthyroidism means it's coming from the thyroid itself. The thyroid is causing the problem. So classification: primary hyperthyroidism and secondary. Primary has to do with the thyroid gland itself. The secondary ones, what's the secondary gland above the thyroid? Pituitary. If I said there was tertiary, what would it be? Hypothalamus. The primary is always the gland itself, and you work your way backwards. So here's your thyrotoxicosis without hyperthyroidism. Again, taking excessive oral thyroid hormones. So examples of primary hyperthyroidism. Graves' disease is the most common one. You also have these toxic nodular goiters, adenomas, and other cancers as well. Examples of secondary hyperthyroidism. Here's your TSH secreting tumor in the pituitary gland. We talked about pituitary gland tumors yesterday, how it depends on what tissues are involved. And that's where you're going to have your problems. So you also have thyrotrophs. Those are the cells in the pituitary gland that make TSH. So if you have a TSH secreting pituitary adenoma, it's going to cause hyperthyroidism because that TSH is going to tell the thyroid, make more T4, T3. Another one, ovarian tumors can also have ectopic thyroid tissues. What did we learn about yesterday with ACTH? What other cancers can also cause ACTH-producing tumors? Lung cancer, specifically oat cell cancers. Now here's another type of tumor that can cause other hormonal releases that are unopposed because they don't have the receptors for T3, T4. So nothing is going to have that negative feedback. Nothing tells it to shut off. It just keeps going. It's just a TSH-producing tumor. So examples of thyrotoxicosis without hyperthyroidism, again, just ingestion of excess thyroid hormone. You can have damage or inflammation to the thyroid, which will just dump thyroid hormone into the system without having hyperthyroidism. It's just dumping them all into the system. Remember, it stores it, and when the release comes, the stimulus comes, it releases the hormone. But it stores it all. But if you get a massive dump of all that thyroid hormone into the system, it causes what's called thyroid storm. And patients have really rapid heart rates, and they can potentially die from that as well. Any destructive processes to the thyroid. Subacute thyroiditis is a painful process, okay? But silent thyroiditis is painless. Some have pain associated with it, some don't. Subacute thyroiditis, inflammation of the thyroid gland in an acute process, they can dump it all out. And some iatrogenic causes, interferon and amiodarone. Amiodarone is a drug that we use a lot. It's used a lot in atrial fibrillation, but it's very toxic. So whenever you see amiodarone, there's a couple of drugs that you'll learn that you want to get labs before you start them on these medications. This is one of them. You want to check thyroid levels, liver levels, to make sure that they're at baseline. So when you give this medication, you want to see if there's any changes, and you know what's going on from there. Okay, moving on to Graves' disease, which is a form of primary hyperthyroidism. It is an autoimmune disease, most common cause of hyperthyroidism, mainly with young women, rate of 10 to 1. There is a positive risk family history here, so it is genetic. And in Graves' disease, it is symmetrically enlarged. Thyroid, you really want to pay attention to the symmetry of that gland. So in Graves' disease, both sides will grow together. So what is going on with Graves' disease? It's an autoimmune process, and the autobody that we're dealing with here, autoantibody, is the TSH receptor autoantibody, also known as TSHR. Okay? With this autoantibody, it sits in that receptor for TSH on the thyroid gland and turns on that thyroid gland and starts pumping out thyroid hormone. So these antibodies act like TSH. They sit in the receptor and they turn on the thyroid. Thyroid becomes very hyperplastic, very vascular. Okay? Now, when this happens, they may be involved in the eye changes seen in Graves' disease. Exophthalmos, the bulging of the eyes. Okay, they get tissue deposited behind the eyeball from all this, and it pushes the eyeball out. Okay. And here's a graphical representation of it. Here's your TSH receptor, and you can see how that autoantibody just sits in it and turns on that thyroid gland. So if you ever see an example in an exam talking about TSH receptor autoantibodies, Graves' disease, because it's turning that gland on. So increase in T3, T4 causes TSH to be shut down. Low TSH, but the autoantibodies continue to stimulate T3, T4 in these patients. Okay, so you're going to have low TSH, high T3, high T4. Signs and symptoms. These are all symptoms of overactivity. Irritable, nervous, emotional lability, poor concentration, tremor. Hyperreflexia is a big one. Here's your exophthalmos. Eyes bulging, protruding, some ptosis or lid lag. They appear to stare. Heat intolerance. Okay, warm skin, weight loss, even though they're eating a lot, they're very hungry, they're eating like crazy, and they're losing weight. Hyperthyroidism. Palpitations, tachycardia, remember this increases cardiac excitation. They're going to have palpitations. Here's your AFib, diarrhea, muscle weakness. Okay, these are all signs and symptoms of hyperthyroidism. So here's exophthalmos here, there's your enlarged thyroid, and then obviously your other signs and symptoms in the middle. And review slide. See, it's all Halloween worked. Yes?
What's the mechanism that causes the muscle weakness?
Because remember, the thyroid is involved in muscle development and growth, and now you don't have it, or you have too much of it. When you go to hyperthyroid, it's a very catabolic environment, so we're breaking down stuff. It turns into a catabolic. So the effects, cardiovascular, heart rate goes up, contractility goes up, cardiac output goes up, pulse pressure, tachycardias, CHF can result if they go into those long-standing, untreated hyperthyroidism. Metabolic changes, increased hepatic gluconeogenesis, weight loss from increased BMR, so their basal metabolic rate is going up, like they're turning up the heat in a furnace. They're just burning through calories like crazy. They're eating like crazy. They're still losing all this weight. They may need vitamins because of may have some vitamin deficiencies. Osteoblast and osteoclast activity are increased, causing low bone mineral density and bone fragility, and increased GI motility, so they're going to the bathroom more. And in GU/GI gyne issues, in women, oligomenorrhea, men, decreased fertility, impotence, ocular changes, proptosis, infiltration of lymphocytes with these proteoglycans, causing edema of the soft tissue, the puffy eye. EOMs may become fibrotic, so you're not going to be able to move as much doing your pen test for the H symbol to see what's going on. Skin changes, warm, velvety skin, non-pitting edema of the lower extremity. They have these nodular plaques. That's what you're seeing there. That's not edema where you're pushing your fingers. It looks like you're pressing into dough. That's what normal edema is like. You put your finger there, you push it. It feels like you're pushing on a sponge, and it gets deformed, and it usually comes back. These are nodular plaques, and that's why it's not really edema. Hyperpigmentation of lower extremity and nail beds. So this is called pretibial mixed edema or thyrotoxic dermopathy, also known as this orange peel texture on the anterior shins of the lower extremity. These are just signs of hyperthyroidism. Again, untreated hyperthyroidism. If you treat these patients, they're going to be okay. And deposition of high hyaluronic acid, proteoglycans, causing the mixed edema. So if you ever see mixed edema mentioned, it's talking about hyperthyroidism. So here's your orange peel texture. Digital clubbing, that's what clubbing is of your fingers. You see this a lot also with people with severe pulmonary diseases. They'll get clubbing. So some complications of hyperthyroidism, the main one is this thyroid storm, also known as thyrotoxic crisis. Can result if Graves is not treated because you get these massive dumps of thyroid hormone into the system. Very rare, but it is a medical emergency. Often precipitated by another illness. Something else happened that triggered this thyroid storm to happen. If patients have those automatic defibrillators in their body, sometimes they will go off multiple times because the device sees the heart rate and can't distinguish it. Is this a normal heart rate or is this ventricular tachycardia because of the thyroid storm? And the device will shock the patient, and then they go back to a normal rhythm. They go back to this fast rhythm because of the thyroid hormone, shocks them again, and they come and see you in the hospital. So that's what thyroid storm is. Tachy, hypertension, fever, nausea, vomiting, agitation, restlessness, and this is where they can go into heart failure when they get this untreated thyroid storm, hypotension and shock, and obviously if you don't treat it, it can be fatal. So that's thyroid storm. And again, guys, when we do endo in the winter, that's when we talk about the treatment and how do we take care of all these patients, what medicines do we give. Here's another one, Nacho Libre. Okay. So now we're dealing with hypothyroidism, also known as mixed edema again. I got to figure out, wait, why is it twice? Anyway, this is what I want you to know. Know this graph because this tells you what's going on with the different thyroid hormones. In primary hypothyroidism, problem with the gland itself, TSH is going to be high and your thyroid hormones are low. If it's secondary hypothyroidism, the pituitary gland is not producing any TSH at all because there's a damage to the pituitary gland. So obviously TSH is going to be low. And because TSH is low, nothing is stimulating the thyroid gland to do anything. So those will be low as well. You will have a question going over TSH is high, T4, T3 is low, where's the problem? Or I'll say TSH is low, T4, T3 is low. Where's the problem? This last one is dealing about the poor peripheral conversion. Remember, T4 and T3. T3 is the more active version. We want the T3. If we have poor conversion, only T3 will be low. T4 is okay. TSH is normal. We just don't have the right conversion. So T3 is low by itself. Main characteristic, again, low T4, T3, serum TSH is going to be elevated. So again, primary, damage to the thyroid gland itself. Here's your congenital, cretinism. Okay, that's when babies are born with defective thyroid glands. You give them some thyroid hormone, and then they're okay. Hashimoto's thyroiditis. Hashimoto's is a transitory disease we'll talk about. It starts off as hyperthyroidism and then devolves into hypothyroidism. But we keep it as a hypothyroidism because the hyper stuff doesn't last very long and they go right to hypo. Iodine deficiency makes sense. You don't have iodine, you can't make T4, T3. Thyroidectomy, obviously that is going to be a primary hypothyroidism. So on your notes, if you have a patient who has a thyroidectomy, you would say hypothyroidism secondary to thyroidectomy. Okay? You have to explain why they have hypothyroidism. And then here's your drug again. Here's your amiodarone. Causes problems with the thyroid gland. Secondary hypothyroidism. This is the problem with the pituitary gland. This is your hypopituitarism. We talked about that yesterday. Remember, there's like 7 hormones coming out of that anterior pituitary. Any of those can have cancer problems and cause deficiencies. And the last one is this hypothalamic disease. Basically, you're lacking TRH. Very, very, very rare, but you can have this as well. TRH doesn't work from the hypothalamus. Nothing is telling the pituitary gland to do anything. No TSH, no T4, no T3. So this is cretinism. This is congenital hypothyroidism. But due to thyroid aplasia or hypoplasia, basically they're not making thyroid. The thyroid gland is messed up. Manifestations for these patients, for these babies: persistent jaundice, so they're going to be yellowing of the skin. Hoarse cry, constipation. Feeding problems, delay in development. When you guys start peds in the winter, one of the biggest things you have to know, like most of peds is going to be a lot of repeat stuff, but the beginning section is all the new stuff, and that's like developmental stuff. At how many months should they be doing this? At 3 months, they should be able to do this. At 6 months, they should do this. At a year, they should do this. Those are developmental progressions. And you'll learn about these things, little milestones. And if they're delayed, you got to think, why is this baby delayed in their development? If it's a thyroid deficiency, there's your answer. Short stature, potentially protruding tongue. If unrecognized and untreated, will lead to mental retardation because they're not going to develop anything. The developmental delay, they won't be able to learn. So, but you can see here, once you treat them, it goes back to normal. They develop normally. But you have to recognize it, and then you treat them with, like, Synthroid, levothyroxine, and they go back to normal. Hypothyroidism. Signs and symptoms develop insidiously. They just come on out of nowhere. Fatigue, cold intolerance. Here's your mixed edema. So mixed edema refers to more of the eyes. I'm sorry. That's why it's in both. It refers to the changes that are going on with the eyes is the mixed edema. Hoarseness, mucous membranes or larynx are thickened, can't concentrate. Decreased sweating, cool and dry skin. That's the opposite of hyper because they don't have the metabolic rate increases that you do with hyperthyroidism. Your metabolic rate actually drops and gets lower. So you're burning less calories at rest, therefore you start gaining weight. Slowing of the movements, menorrhagia, weight gain, and constipation. Complications of hypothyroidism, again, untreated. Okay, a lot of these things are all untreated. If you treat them, they're not going to have these issues. Mortality rate is very high despite treatment. Often occurs in the elderly with these mixed edema comas, precipitated by some sort of underlying event. They went on some medications to sleep, stroke, sepsis. Signs and symptoms of a mixed edema coma, everything with hypothyroidism, but now they have decreased levels of consciousness, maybe seizures going on with these very, very, very low thyroid levels. And then here's like a summary slide for your signs and symptoms. So here is Hashimoto's thyroiditis, also known as chronic lymphocytic thyroiditis. This is the most common form of hypothyroidism. Graves is the most common form of hyperthyroidism. 3 to 4% of the population, again, more women than males, frequently diagnosed between the 3rd and 5th decades. So, with this one, we have different things we have to look for in the blood. With Hashimoto's thyroiditis, they can either have anti-TPO. So now remember, TPO is needed to generate thyroid hormone. Now they have an antibody that's going against TPO. So you're not going to have any more. You can't make more thyroid hormone without TPO. So now we have a case where we're getting rid of it. You're not going to make any thyroid hormone. Or you can also have anti-thyroglobulin antibodies, TGAB. Thyroglobulin is used to help move the hormone in and out of the colloid into the follicular space. If you don't have that thyroglobulin, you can't move it. Therefore, you can't make thyroid hormone. So these two things are important. That's why I kept stressing before. TPO and thyroglobulin are the two things we need. Now we have Hashimoto's that says we don't have those things anymore. You can't make thyroid hormone. So very high levels of these antibodies clues you in that this is Hashimoto's thyroiditis versus just regular hypothyroidism. So it's a chronic autoimmune disorder via CD8. They destroy all the follicles. Anti-TSH receptor antibodies are also here. These are the opposite of Graves'. So just like the TSH receptor antibody that we have at Graves' that turns on the thyroid gland, now we have an anti-TSH receptor antibody. It's going to sit in that receptor, but instead of turning it on, it turns it off. Same thing, just the opposite effect. Occupies the TSH receptor and turns off the thyroid gland so it doesn't produce anything. Therefore, hypothyroidism. Here again is your anti-TPO. Here's your anti-thyroid globulin. So these are 4 ways we can get hypothyroidism with Hashimoto's thyroiditis. Okay, initial presentation for Hashimoto's: painless, diffusely enlarged thyroid, or goiter, because they're going to have an enlarged thyroid, due to the inflammatory process for the autoimmune system. So again, it's painless. So the thyroid eventually atrophies after the cell dies in some patients. So you get thyroid atrophy. If you're not using it, it's going to shrink and go away. Okay, often associated with other autoimmune diseases. So I mentioned that yesterday, that a lot of these autoimmune diseases pop up together. So Hashimoto's is another one that will pop up later on next semester. Physical exam for Hashimoto's. Again, painless, symmetrically enlarged. And I stress this whole thing because we get to thyroid cancer, you'll see how things change. Feels firm and rubbery with an irregular surface, can impair swallowing, and may only be one firm lobe or a single firm lobe nodule, may be palpable, because parts of the gland are being destroyed by this autoimmune process. So it gives you that illusion of feeling like they're nodules just because the surrounding tissue next to it necrosed and died. So if you're feeling irregularness because part of the thyroid gland has been destroyed. Labs, 90% of the patients are going to have anti-TPO antibodies on blood checks. 50% will have the anti-thyroglobulin ones. So if you see anything with anti-TPO, anti-TG, it's going to be Hashimoto's. They're the most common ones that go along with it. Cell membrane antibodies are present. Those are those. And T4 TSH may be normal. And here's where that peripheral conversion may be having a problem. So you may see this conversion problem with Hashimoto's as well. So you just order what's called a thyroid panel. It gives you TSH and your free T4, free T3. It's all together. So you just order a thyroid panel. You don't have to worry about getting specific. Just say, I want to order this, and you get all the stuff with it. Remember, thyroid panels are not normal routine screening, so you have to actually order them separately. It's not part of a CBC, a CMP, BMP, any of that stuff. It's all by itself. So signs and symptoms: slowed mentation, forgetfulness, decreased hearing, ataxia. Here's your DTRs, paresthesias. Because of this mixed edema, this tissue swelling that goes on. Yes?
You said, are the antibody ones also included, or do you have to order those separately?
So the way that it works, you have to order the thyroid panel first, and then you kind of get an idea, and then you can order all those enzymes afterwards, the anti stuff. It's because you don't know what's going on, so you kind of just get a thyroid panel first, and then you can go from there. If you're in endocrinology and you suspect that they're coming in with something, then you probably would order it anyway, just because your suspicion's high. But if it's just normal, like the routine coming in for a check, and you're in internal medicine, you're just going to order a normal thyroid panel, and if it comes back abnormal, then either you'll refer them to endo, you'll get an ultrasound of the thyroid, you'll get more testing. But you got to do that first initial stuff first. Musculoskeletal stuff: muscle weakness, cramp, stiffness. Cardiac, the opposite stuff: bradycardia, low cardiac output. They can be very tired and sluggish. Respiratory changes: increased incidence of sleep apnea, high cholesterol, normochromic, normocytic anemias with thyroid, hypothyroidism. Constipation is here. Skin's cool and dry, these proteoglycan complexes, again, non-pitting edema, that's that mixed edema. Face appears puffy, coarse features. Hair becomes very brittle. Thinning of the hair is usually one of the big signs for hypothyroidism. Hair gets very thin, brittle, falls out. And so here are some examples: the puffiness around the eyes, thinning of the hair, the mixed edema going on with the puffiness from the proteoglycans. And now we'll move on to nodular thyroid diseases. There's 3 of them we have to go through. So the first one is nodular disease: disordered growth of your thyroid cells. They're not growing properly. Gradual development of fibrosis. So we know whenever you have fibrosis, that tissue is dead, it's not coming back. Occurs about 25% of adults. The nodules can be different styles. It can be alone by themselves, multiple. A functional or non-functional nodule is very important to know. Meaning, if it's a functional nodule, it's still going to act like thyroid tissue. If it's a non-functioning nodule, it's usually just something else, other type of cells that are there causing the enlargement in the tumor. And we'll focus on this in a minute when we talk about different scans we can do for the thyroid gland. Okay, so the first one, here we go. Non-toxic multinodular goiter. So non-toxic, non-cancerous, multinodular, multiple nodes throughout the thyroid, goiter, enlarged thyroid. Asymptomatic, okay, so painless. About 12% of adults, again, more females than males, higher incidence the older you get. The variation in size of the nodules also exists. Some, depending on where the things are going on, you may have fluid-filled lesions, if it's in the colloid space, in the cystic areas. Fibrosis is extensive. You can also have some hemorrhage going on. Remember, the thyroid has high vascularity. Okay, if those vessels burst, they can cause hemorrhage in the thyroid. Okay, most patients are asymptomatic and euthyroid. Again, we talked about euvolemia yesterday. Whenever you see the word EU in front of a word, that means normal status for that value. Dysphagia makes sense. Thyroid's enlarged, going to compress the esophagus, and they have problems swallowing. Now, complications. A sudden pain will indicate hemorrhage or malignancy. So once they start becoming painful, then we're worried about malignancy. Malignancy may also cause hoarseness with involvement of that laryngeal nerve. Where else have we talked about this laryngeal nerve? In my class. What valve abnormality can cause? Well, we know the chamber's got to get big. Mitral stenosis. Remember, mitral stenosis, that left atrium gets big and compresses that left recurrent laryngeal nerve. They call that Horner syndrome. Same thing can happen here. Now moving on to a toxic nodular goiter. Now we're toxic. They are symptomatic. They are going to have pain and problems with this. One or more of these nodules produce too much thyroid hormone, causing thyrotoxicosis. Okay, so that's why thyrotoxicosis is the umbrella term just for high thyroid levels. Hyperthyroidism is a part of that. Here's another cause for high thyroid levels. Enlarged thyroid gland with all these nodules. If the nodules are functioning, they're going to produce a ton of T3, T4 as well. Most often in the elderly, develops from a simple goiter over years. Presentation, again, here's your AFib. That's why I said any elderly patient coming in with AFib, new onset, check thyroid levels. Nervousness, tremor, weight loss. Etiology could be after receiving IV iodine or by mouth. For example, CT scans, heart caths. They get IV iodine. Anything containing iodine, such as amiodarone, can cause problem with the thyroid. Again, that's why I mentioned before. If you ever start someone on amio, got to check liver and thyroid levels first. So this is a toxic adenoma. All that is the cancer. Hyperfunctioning solitary nodule. Okay, produces thyrotoxicosis because it's functioning. So it's producing tons of thyroid hormone. Often mild symptoms, large enough to palpate, but no signs and symptoms of Graves' disease. So they have this excess thyroid hormone, but they don't have the signs and symptoms like Graves' diseases would as well. So this is called a thyroid scan. What it does, it looks at nuclear medicine imaging. We take some of your blood out and we tag it with the radioisotope. In this case, we give it iodine because we know the only place iodine is going to be taken up is in the thyroid gland. So we tag the iodine with this marker. We inject your blood back into you, and we do a scan of your thyroid, and we see where this iodine was taken up by the thyroid gland. So you see here, we have a big area right there that's being sucking up a lot of that iodine. That's called a hot nodule because it's functioning, it's working, it's making a ton of thyroid hormone. Okay? So that's what a thyroid adenoma, that's a thyroid scan. So if you've ever seen this guy, that house flipping show, well, basically, he didn't know he had toxic adenoma of his thyroid. People who watched his show saw that his neck was bulging at the bottom. They all wrote in and say, hey, get your thyroid checked. Turns out he had thyroid cancer and got it taken out. But it was from the TV show. People found it, like fans found it, and that's how he got found out. So risk factors for malignancy with a thyroid nodule. Number 1, radiation exposure. Okay, that's why you gotta be careful with CT scans. Don't be like Oprah and you get a CT, you get one, and you get one. That's how a lot of the ER docs act. Like everyone gets a CT scan. Well, there's a problem with those. They get too much. That's why if you go to the dentist, what do they have you do? Wear the lead sheet. If you ever worked in a cath lab or a fluoroscopy suite, they have you even wear the neck cover to cover your thyroid so it doesn't get irradiated. So radiation is bad for thyroid. Nuclear disasters like Chernobyl. Now, if you watch that show on HBO, they were loading up with iodine. I don't know if that's real or not. I don't know if that works. But there were but I think it was dramatized for that show, but they were taking iodine pills to load up their thyroid with the pure iodine so they didn't get the radioactive iodine. But you have to do that forever. I don't think you can do that just one day, but that part I think was dramatized. Family history of any papillary or medullary thyroid cancer, and male sex is higher for these malignancies. Tumor characteristics, that would be very high likelihood this is cancer. Rapidly enlarging nodule, so that size is getting bigger and bigger and bigger fast. That's a high indication this is cancer. Vocal cord involvement, high likelihood this is malignancy, this is cancer. A fixed hard nodule, Cancer. If you can move it around, it's movable. Shouldn't be really lower your likelihood of it being cancer. Cervical lymphadenopathy. If you start getting lymph node involvement near the thyroid, that can tell you this is malignant as well. Dysphagia, stridor. What's stridor? When you breathe in, you have a really big audible wheeze or noise to try and get it through. So this is a great summary slide talking about what happens with pituitary and thyroid, looking at your normal, hyperthyroidism, hypo, and a secondary hypothyroidism. What happens with your labs? Okay? That was my original Halloween from years ago. You ever see Superbad? You ever saw the movie, you don't get it. And it's Eli. Anyway, Monday is EKG quiz. Take 10 minutes. We'll come back at 3:30 and we'll do our Kahoot review.